Welcome to Baby Snugs and Coffee Mugs. I'm Krista.
And I'm Kelsey. We're both labor and delivery nurses from Minnesota. In this podcast, we'll be covering all things pregnancy, delivering in a hospital, and caring for yourself and baby postpartum.
This podcast is meant for educational and entertainment purposes only, so please seek medical advice from your healthcare provider. We are so excited for you to join us, so grab your coffee, snuggle up, and keep on listening.
Cheers!
Cheers! Welcome back, everybody, to episode 16 of Snugs and Mugs.
Welcome, everyone. This week, we're going to talk about induction of labor. So what that means, according to the American College of Obstetricians and Gynecologists, is that we are trying to achieve a vaginal delivery by stimulating uterine contractions before the spontaneous onset of labor, meaning that we are trying to put your body into labor if it's not quite ready yet, or if there's reasons to be induced. There is a long list of medical reasons, and we will go through all of those with you.
Yes. So, we're going to start out by telling you guys kind of the reasons that you could be induced, and then we'll follow that up with what exactly being induced is. We'll go through all those kind of ways that we can induce you that Kelsey brought up. So, let's start off with the reasons that you could be induced. So, I would say the number one reason, at least lately, that we have seen that patients are being induced is for high blood pressure. So, gestational hypertension or preeclampsia. I feel like most people at this time know what that is. I feel like it's so common. People have heard that a lot.
I agree. I think the majority of our patients are high blood pressure right now.
Yeah. Yep. Second thing would be having diabetes. So whether this be you have type 1, type 2, or gestational diabetes. It doesn't matter if you are diet controlled or insulin dependent gestational diabetes. Typically, this is a reason that you are put on an induction list. Next, that brings us to post dates. So a lot of people, I think you get to your due date and anything after that's considered post dates, and it technically is not. You aren't considered post dates until you hit 41 weeks. So 40 weeks is your due date, 41 weeks is considered post dates. And the reason why we induce people because of this is your placenta has a shelf life, basically, which is kind of cool. It's one of your only organs that has that short of a shelf life, which kind of stinks. But basically, your placenta is functional until about 42 weeks. So ideally, if you get to that 41-week mark, they are going to put you on the induction schedule and try to get you delivered by 42 weeks. Next, let's talk about the size of the baby. So, obviously your baby can just be average size. It can be too little. It could be too small. So there are a couple terms that you might hear your provider talk about when it comes to the size of your baby. So if your baby is measuring really small, they are definitely going to be keeping an eye on this for probably from your 20-week visit on. But the terms you will hear is IUGR, which stands for intrauterine growth restriction, or the newer term that I feel like we're supposed to be using is FGR, which is fetal growth restriction. So basically this means for whatever reason, your baby is measuring small and isn't growing as much as they would like the baby to grow. So for example, with my second baby, we had a 2-vessel cord. I feel like I've probably mentioned this before. But we had a 2-vessel cord, meaning that there was one less vessel in that umbilical cord than there should be. And she had been measuring small from our 20-week ultrasound all the way until I delivered. She was never technically IUGR. She was just above it, so I did not have to be induced for that. But that is a reason why she was at risk for IUGR or fetal growth restriction was because of that 2-vessel cord. So that's kind of just an example for you guys. And then there is also your baby measuring too big. So that would be called macrosomia, if you have heard anyone talk about that before. And also there could be no reason or there could be a reason why your baby's measuring bigger. Oftentimes babies of diabetic mothers will be measuring a little bit bigger. And sometimes you just have a big baby and that's okay. But they don't want your baby, if it's measuring too big, they basically don't want your baby to be put in this scenario where it doesn't fit out of your pelvis or where it gets stuck coming out of your pelvis. So ideally we catch that at the end. With that being said, with a small baby or a big baby, they monitor the size of the baby with an ultrasound. At the end of pregnancy, obviously you know your baby is pretty cramped in there. There's not a whole lot of wiggle room for the baby anymore. And so getting an accurate ultrasound can be a little bit difficult at this point. For me, at my 39-week ultrasound with my second baby, they ended up being 15 ounces off. So she actually was a lot smaller than they thought she was going to be, which so you can kind of see how they can be off a little bit. But I've also seen them be literally exactly on.
I was just going to say that. They are either spot on or sometimes not even close, but you kind of just have to take the best of the information that you have. So.
Yeah, exactly. Next is your amniotic fluid levels. So again, I'm going to say some sort of technical terms here, but I'll kind of talk you guys through all of this. So you could have too much amniotic fluid, which is called polyhydramnios. And if you're having too much fluid, they most likely are going to want to induce you to kind of, it's kind of hard for you to go into labor when you have too much fluid because your baby's head doesn't really get down on the cervix. You can also have not enough fluid, and that's called oligohydramnios. And then you also could prematurely rupture. So we definitely have patients that come in that their water breaks way too early, and then they just kind of sit there if their body doesn't spontaneously go into labor. If you are able to maintain being pregnant and not go into labor, we typically induce our patients around 34 to 35 weeks. So again, another reason why you'd need to be induced is your water broke and nothing happened.
Yeah, and I think even the flip side too is if your water breaks and you are term and your body doesn't kick into labor, those would be reasons to technically induce you as well.
Yeah, yep, yeah, you're right. Actually, that happened to me too with the second. She's a trouble child.
You got everything.
I know, right? Yeah, my water broke and literally nothing happened. I'm like, isn't it supposed to come quicker this time?
Oh, you would think.
Right.
A couple other medical reasons. IVF pregnancies that puts you at high risk right away. So they will talk about inducing you, I think, typically around 39 weeks. Mm-hmm. Also, AMA, advanced maternal age.
Yeah.
Once you hit 35, your pregnancy is also higher risk. So they talk about that induction. Multiples, twins, triplets, anything more. Nope, I lied. We're not inducing, only for twins typically at our facility at least. Again, our facility does not do vaginal triplets, but twins, they could.
If anyone does do vaginal triplets at your hospital, let us know, because I'm kind of curious. I've never heard of that being a thing, but
yeah, that is interesting.
Because I feel like people do things very differently than we do in the Midwest. So
no, you're right.
I'd be interested to hear if that is an option anywhere, but as far as I know it, it's not. What is next? Okay, now we're to advanced cervical dilation. So basically what this means is that your cervix is open enough that we could easily induce you, but you're not actually in labor. So advanced cervical dilation is anything higher than 4 centimeters dilated. So I have seen patients be 5, 6, 7 centimeters dilated and not be in labor. They just kind of walk around day to day, and like that's just where their cervix is at. So with that being said, if you did go into labor or say your water broke, you obviously are way closer to delivery than if you were 2 centimeters. So there are definitely times where if you're walking around, you're 7 centimeters, it's your second baby, they're like, let's just have you be induced so that you don't have a baby in the car if that's not your plan.
Yeah, I think you're kind of like the talk of the town. Like, you're 7 centimeters, we're going to have to send you to the hospital probably now.
Yeah, yep, exactly. So I have definitely seen that actually quite a few times.
I have too, which is awesome. Good for you.
I know. And it always goes just so smooth because like your body's just ready. It just needs the contractions. And then there's like any other medical reason. So of course everybody has their own medical history. And there is a huge list of different medical diagnoses that people could have. So it's kind of up to your provider if that is a reason why you should be delivered a little earlier or at a certain amount of weeks. And then that brings us to a social induction. So a social induction basically means that you have no medical reason to be induced, which everything we just talked about was a medical reason. But you would like to be delivered. You are done being pregnant. You're like, yep, I'm over this. I would like my baby to come out now. So with that being said, at our facility, you do have to be 39 weeks. We do not socially induce people before that. And then you should have a favorable cervix. So what is a favorable cervix? Great question, Krista. Basically, this means that your cervix is ready to have Pitocin. So you want to be started to be dilated, so about 3 centimeters. Your cervix is starting to thin out and it's nice and soft. So If you ever hear that your provider say your cervix is favorable, that's a great thing to hear. You want to hear that. That means even if you're not being induced, that just means your body's more ready for labor. So 39 weeks and your cervix needs to be ready to go. Obviously, there are times where your cervix is not ready, and this is when we'll kind of talk about these next few steps of how do we get your cervix or your body ready for labor. So we use kind of 4 different methods when it comes to inducing labor at our facility, and we're going to start out with talking about site attack.
Yeah, so exactly like Krista said, say that you have a medical reason that you need to be induced. Your body's not quite ready for it. They're telling you that your cervix is closed. Maybe it's pretty thick. One of the first medications that they're going to start out with is Cytotec. Now, one reason you can't have Cytotec is a C-section. So if you've had a prior C-section, this is probably not going to be an option for you. But essentially, it is a medication that is going to soften the cervix. They will interchangeably use the word ripening too if you use that. But essentially, there's 3 different ways that you can take this. It is a pill, so you can swallow it like a normal medication. Our midwives, I think, are super in favor of Bucally, it's called. Yeah. So you put the medication just right in your cheek and it melts. And
takes a little while. But
it does take a while, and I guess I've never really had anybody say that it tastes bad. But
I don't think they say it tastes good. But they're just like, I don't know. It's like
it's a melting
pill. It's just sitting there. So
yeah. A third way is placing it vaginally. So they will place it up near your cervix. At our facility, our providers do that, but I think there are facilities out there that nurses are trained to do that as well. Prior to putting this medication either vaginally or you swallowing it, we are going to put you on the monitor. We want to watch your contractions. If you are contracting too much, meaning more than 2 to 3 minutes, we can't control Cytotec. Once it's in your system, if you start contracting even more, it can affect baby, it can stress baby out. So we are right away making sure baby is tolerating everything in general and that you're not contracting too much. If you're not, we will give that. At our facility, we will monitor for another 1 to 2 hours. Again, just making sure that baby's tolerating those contractions that this medication is giving you. I have heard that other facilities do continuous monitoring. I've seen this medication kick people into labor right away, so maybe that's the reason behind that. Typically, I see that you get pretty crampy for like a good hour. And I think after that, it kind of subsides.
Yeah, I think most of our patients say like it feels like period cramps. Like they're not like as painful as contractions unless it's kicking you into labor.
Right.
But you kind of feel that constant crampy, like achy feeling that you can feel if you have period cramps.
Yeah, same. So then we give this medication every 4 hours. So you get the medication, you're monitored, everything's good. We'll probably take you off for a little bit. We will reassess. Typically, the provider will check that cervix again, see where you're at. If you're still about that closed or pretty thick, we will offer another dose. Again, as long as you're not contracting too much. Typically, we give a max of 6 doses. I don't know if that's the same for every facility. I don't know what protocol that follows, just knowing that we do about 6. And if we're getting close to the 6, then our providers will have a conversation with our patients on the next steps or what else could be done. Let's see. So once your cervix starts opening and we can place a Foley bulb, then we would be done with the Cytotec at that point. So let's talk about a Foley bulb because that's the next step.
Yeah, so ideally, the Foley bulb could be your first thing and skip the Cytotec. But
very true.
So placing a Foley bulb. So first of all, I'll explain to you what a Foley bulb is. So if you've ever had a Foley catheter before, it looks exactly the same. So it's a flimsy tube that has a little inflatable balloon at the end. So what the provider, which we have providers place it at our facility, what the provider will do is have you lay back kind of just like you're getting your cervix checked. Some of them use a speculum to place it. Some of them do not. It's just provider dependent. And what they will do is they will put this catheter up into your uterus, and then we fill that little balloon at the end with 30 mils of sterile water. Once it is filled, they kind of ensure that it's in the right place, make sure it's inside of the uterus. And then what we're going to do is we're going to pull it nice and tight against the cervix, which sounds terrible, which it kind of is. We'll pull that tube nice and tight, pull traction on it, and then we tape it to one of your legs. Why we want it so tight is so that balloon is putting pressure onto the cervix and helping it thin and to dilate. Where we work, we have two different types of Foleys that we use. We have our normal Foley bulb, which is what I just explained. And then we also have a Cook Foley bulb, and that basically is there's two balloons. One goes inside of the uterus, and they do fill up a little bit more than this one does. And then there's one like right outside of your cervix, so in your vaginal canal. And they've kind of almost like squeezed together and put pressure on both sides of your cervix. I would say we more typically use the normal Foley bulb, which will get you to about 3-ish centimeters, but we do sometimes use that other Cook Foley bulb, which will get you to about 4 to 5 centimeters. I do always try to remind my patients that it is great that you do get to 3, 4, or 5 centimeters, but just remember you're not technically in labor yet, which you could go into labor from a Foley bulb. That does happen. It's just not very common. So typically what happens is when that catheter is taped to your leg, it pulls traction and you get cramping. So just like the side attack, you're going to kind of feel those period cramps. It kind of feels weird that there's something extra kind of in there. And you're going to basically cramp until it falls out. So the most common thing that we do is we will place the Foley bulb, monitor you for anywhere between a half hour and an hour, and then most of our patients go home with them. There are times where we do have our patients stay the night depending on their medical diagnosis, but typically you're going home with this in place. So that means it's kind of up to you to monitor the placement of it. So what you will do is anytime you go up to the bathroom is you just kind of tug on the part that's sticking out and just see if it's ready to come out. And you will be able to tell. If you go to tug on it and it is painful, that means it's still up in the uterus and still pulling on that cervix. If you go and you're like, oh, I don't think that's painful, and you start pulling and it starts coming out, that means it slipped through your cervix, it is out of your uterus, and now is in just your vaginal vault, and you can just go ahead and pull it out. Most people say it feels like pulling a tampon out. It's kind of that same sensation.
I would say they say it's relief.
Yeah, yes. And like a lot of times because one, you stop cramping and that's how you know it came out of your uterus. But also you went from having just a little bit of that Foley sticking out of you to a whole lot more because it came out of the cervix. So you can kind of gauge it by that too. But when it comes out, you just toss it out and throw it in the garbage. If you are staying at the hospital and you don't feel comfortable tugging on it yourself, that's okay. Your nurses can tug on it for you. We don't mind. That's why we're there. And then basically, if you do not have it come out, that is okay. You return in the morning for your Pitocin, and there's kind of multiple things that they could do if it's not out. I've seen them take it out and start Pitocin. I've had them run Pitocin with it in. I've had them give Cytotec with it in. I've had them take it out and give Cytotec. So it's really just dependent on the situation. But I would say more chances than not, it falls out at home. You come back in the morning, and then you are ready for Pitocin. There is one contraindication to using a Foley bulb, and that is if your water is broke. So with your water already being broke, that kind of barrier to infection getting up into your uterus is gone. So we don't like to obviously put anything into your uterus once that barrier is gone. So if your water is broke, typically a Foley bulb will not be an option for you. So for smoothness sake, let's say you're at home, your Foley bulb falls out, you get a great night's sleep, and then you wake up in the morning and you come back to the hospital and you are ready for Pitocin. So let's go kind of through what Pitocin is.
Yeah, so Pitocin is a medication that goes through your IV. Pitocin, interchangeable with oxytocin. You guys know what oxytocin is. You've learned it. It's the hormone in our bodies. That is what's getting you ready for labor. So Pitocin is basically a man-made form of oxytocin. It works beautifully. It is like, hey, let's get that body going into labor, and it typically will work pretty well. That being said, it does go in your IV. We're typically running fluids with it, and we are using it to control your contractions. So you will be on the monitor the entire time. We want to make sure that baby's going to tolerate us controlling your contractions. We start it at a pretty low rate, and we will gradually increase it as your body is ready for it. So again, we're trying to get that every 2 to 3 minutes. Also, we want you painful.
Yeah.
Those painful contractions are what's going to do it for you.
We are the only floor in the hospital that wants people to be in pain.
And I tell my patients that, unfortunately, but just remember that that means that we're getting closer.
Exactly.
Pitocin is a pretty fast-acting medication. So, unlike Cytotec, we can't control what your contractions are doing. But with Pitocin, if you start contracting too much or baby's getting stressed out by the Pitocin, we can turn it off, give you a little extra fluids, and everything should kind of smooth out a little bit better.
Yep, it leaves your body really, really quickly.
Let's see. Like we said, you're hooked up to your IV. You still have to be hooked up to the monitors, monitor baby. You can still get up and move around. I think a lot of people are like, nope, that just means I'm going to be stuck in bed. That means I have to get an epidural. None of those things are the case.
No.
You can still go natural if that was your goal. Again, you're going to be hooked up to more. There's a little bit more tricks. You might see your nurse a little bit more because we're always controlling that monitor for baby's heart rate. But it's just to make sure everybody's safe.
And we have portable monitors at our facility. So yes, you do have to have the monitors attached to you at all times, but we have kind of two different types that we can use where you're not stuck to the monitor to the bed. You have like this little purse, we call it a little purse that you carry around with you. So you still have that ability to move. And like Kelsey said, you don't have to get an epidural just because you're being induced. I have had plenty of patients that were induced and they still delivered without any pain medication. So that doesn't mean you have to have an epidural.
Not at all. So just check with your provider, because I think that's another thing that people get really bothered about being induced is, having to be hooked up to everything. But there's ways to do it, and we're there to help.
Another way we can go about kind of inducing labor, which we did kind of talk about this in our labor interventions episode, but is AROM, so artificial rupture of membranes or breaking your water. This is a really, really great option for those who are coming in already dilated. So if you're that lucky person that is 5 centimeters strolling around town, this is a great option for you to just kind of get your water broke and see if that just naturally kicks you into labor, because a lot of the times it does. So if you guys didn't listen to that episode, when we break your water, what we will do is we put you on the monitor, make sure baby is doing okay at that time. Again, it's like a cervical exam, just a little bit longer than normal. And the provider is going to use basically this little amni hook, it's called, and it looks exactly like a crochet hook. It's just plastic. And what they are going to do is they are going to check your cervix, make sure your baby's head is in a good position to do this. So they will not do it if your baby's head is not far enough into your pelvis. And they'll just take that little crochet hook and just nick a little hole in your bag of water and let all your fluid come out. Once that fluid is gone, that little cushion between your baby's head and your cervix is gone, and more times than not, it is going to make you more painful and kind of make you contract more.
Yeah, so breaking your water releases natural oxytocin. So talking about using that Pitocin versus just breaking your water, it should release all those natural hormones to start having your body contract on its own, which would be awesome.
So you could need some of these, you could only need one of these, you could need all of these. There are times where we're doing all of the things. You did Cytotec, the Foley bulb, now you're on Pitocin, and we still break your water to kind of keep things going. So just know that these are all kind of potential things. It doesn't mean you're going to have all of them. It doesn't mean that you won't have all of them. These are kind of just all of the different things that we use to kind of induce your labor and keep your labor going until you deliver.
Yeah, there is one medication that I just want to touch on, just because if you go into your facility and you're like, oh, they didn't talk about this. It's called Cervidil. We do not use it at our facility. I think a lot of other facilities use it. I think we used to use it before our time, at least. Just talk to your providers about it. If they start bringing that up, we're not going to teach you on it. We don't know enough about it, but just keep that in the back of your mind.
Exactly. So that kind of ends what we have to talk about and explain to you guys about induction. One little thing I want to add, because I think all of the time my patients come in and if they have to have an induction and they didn't want to have one, they're really bummed. And I feel like often patients feel like they failed or that their body failed because it didn't naturally go into labor. And it's okay. It is okay. You did not do anything wrong. You didn't fail. You're just living your life and you're doing your best, and it is okay. So I think there's just this huge stigma with people needing to be induced, and there are just benefits for induction sometimes, and it is okay if you have to be induced, and it's okay to be bummed about it, but you definitely did not do anything wrong. So I just want people to know that an induction does not mean failure. It just, that's the way your baby's coming out.
I think that's a great clarification. Also, you guys just be prepared if you are starting from the beginning of like needing side attack and needing all of it. It is a long process. Yeah. You can be there a couple of days. Just remember that your body just was not quite ready yet. We are trying to make that body go into labor. Again, it's a process, but it's okay. It's doing all the right things. And again, it's for your safety, your baby's safety.
Mm-hmm. That's a good point. Yeah. So again, if you guys have questions, as always, please let us know. But other than that, we will probably catch up with you guys next season. Yes. We are going to take a little holiday break. Relax with our families, get some other things done in life.
Exactly.
But we really, really appreciate you guys listening to us and contacting us and being a part of this new experience for us.
We love the support. And again, we will be still looking at our messages. So send us stuff. We love hearing from you guys.
And we will talk to you again in 2024.